Good morning. We have a small but a select audience today. Appreciate you all being here. The association is generous in providing ACAPS, the American Council of Academic Plastic Surgeons, this 1-hour panel at each meeting that's focused on plastic surgery education, a topic of focus of all of us. Today we're going to address 4 separate but somewhat related issues in contemporary plastic surgery education. The first speaker will be Bill Hoffman, who's going to talk about engaging full-time and clinical faculty educators. Format will be 10-minute talks, 3 minutes for questions after each of the talks, and then we have at the end 8 minutes to pull it together and have comments and questions from the audience, which will be, I think, valuable given the topics. Thanks. Bill.
Thanks. I appreciate the opportunity to talk this morning. I appreciate all of you guys showing up early for this talk, and I want to thank Mike especially for letting me be the first speaker when everybody's having breakfast. I actually, the original charge was to talk about clinical faculty, so I'm focusing on that in this talk, but I have a little bit about our full-time faculty. San Francisco is a little different from many cities. It's small, but it's actually getting harder and harder to get across town as it gets more packed with people. But one of the things that's different about it is that we have is that no one leaves. I put this little line at the bottom. People don't just leave their hearts in San Francisco; they just don't leave. So the talent that we have in San Francisco in clinical practice is actually quite remarkable, and that lets us recruit people who are outstanding clinical faculty. And at CPMC, which is sort of our rival establishment across town, they were actually Stanford's medical center in San Francisco until the 60s, and still really perform at a very high level. So those are things that contribute to our clinical faculty. The other thing is that in terms of our full-time faculty, we're very spread out. We are working at the VA. This is our main medical center here. We have a new children's hospital here near downtown. CPMC is up here. San Francisco General's over here. And we're adding in Oakland Children's, which is off the map here. So we're very spread out, and whenever I visit another institution, like when I went to Pittsburgh or other places, seeing everybody's offices in the same building together is always something that makes me kind of jealous. Just historically, also there's a reason why we have a close tie with the community. We're an old program. We started in the early 50s. And now we're fully integrated. But when the program was first started, it was actually the chief was Harry Blackfield, who was in private practice and ran the program from his office, which was at another hospital from the university. And it wasn't until the late 70s that we had full-time faculty in plastic surgery. So there was a close relationship all along. This is just basically also looking at the fact that we have residents rotating at many sites all over the city, and are looking at actually adding some more sites so that we are stretched out. So we have a great full-time faculty. And currently 10 in addition to myself, hiring number 11 as we speak. When I was thinking about what are the incentives for full-time faculty to teach, it's really sort of an assumption that they'll teach. That's part of the reason they're at the university and why they stay at the university. It's interesting. We actually haven't had all of these people actually started their careers at UCSF and are still here. And some of them have only been there for a few years, but some have been there for a long time. So nobody's actually, we've had people leave, but we haven't really had a lot of turnover. So some of the things we've done have to kind of encourage. Not everybody is teaching at the same level, and some of the things we've done is to reorganize some of the teaching programs so that we have now our didactic sessions, which are weekly, are organized by the residents, and now we organize them by topic, and each topic has an assigned faculty mentor. The residents actually give the talks, but the faculty supervise them, and so everyone, it goes in a rotation, but everybody is participating over the course of the year. Journal Club also, we went to a topic-based approach to Journal Club, so we may not have as many faculty at each one, but we have specific people, again, who are overseeing this. And then, as I always tell the residents when they're filling out their survey for the ACGME, I said, you know, when they ask you if your faculty are interested in teaching, when they sit next to you and watch you do a tram or whatever you're doing for 8 hours, that's teaching, actually, so don't forget that. And in fact, one of the advantages of having this kind of spread out program is that frequently we only have one resident on each rotation, and they have a lot of one-on-one time with faculty in the clinic and the OR. This is just expectation. This is the door of my office. This is a close-up of a fortune cookie that I got it. It's partly for people who come in to ask for more money. It's also helpful for me every day to see that. But then the clinical faculty, this is a partial list actually, but these are the people who really participate to a large extent. And you'll see there are names on here that are pretty prominent in plastic surgery. I was looking, I think half of them are members of this organization. And this is a very talented group, and it's been great that they've been willing to participate, and they're very open to having the residents work with them when they're on rotations at their hospitals and in reverse. And I'll show you a couple of things. The person I left off is Gil Gradinger, who's been the shining example to all of them of how a clinical faculty person can participate. Until he had a little illness about 1.5 years ago, he probably had the best attendance record at our conferences of all of our faculty together, and he helped organize our cosmetic clinic for the residents, which I'll talk about in a minute. But he's been, I call him the godfather, mostly just because he's sort of like a godfather to me in plastic surgery, but he's been just fantastic and a huge addition. So why would anybody do this for no money? Gil actually said really all he wanted was free parking, and I never could get that for him. Obviously, there's intellectual stimulation. All of our faculty, our clinical faculty, have a faculty appointment, which gains them things like library access with full text things, and clinical faculty. There's a clinical faculty association that's pretty vibrant, actually. We have awesome residents. At least I think they're awesome, and really all of them, they're very, they all work hard, they all read a lot, and they are good to teach, and I think teaching is rewarding in itself. This is just a screenshot of our Clinical Faculty Association website, where I learned that you can get reduced rates at the gym, among other things. We have 2 gyms that are pretty nice, and and I think that partly, the fact that the university recognizes volunteer faculty helps people to feel appreciated and that they're valued. We do. Some of them participate through clinical rotations. The most important one to us is at California Pacific Medical Center. It was interesting that there was a little rift in the pediatric world. Stanford actually took over pediatrics at California Pacific a while ago, and that's sort of in flux. But at the time, the general surgery department actually pulled their residents out because they were so mad about this, and they told me they wanted me to do that, and I wouldn't do it, and because it's such a valuable rotation. And the most valuable rotation is when they work at the Bunkie Clinic. I was actually the second resident to go over there, which was a little while ago. But so that's a long-standing relationship. I worked with Harry when he was there, and now his son Greg runs the clinic, and they have an all-star group that does microsurgery every day pretty much, and our residents really get well trained there, and they're very welcome there. And they've and even though all of those guys train somewhere else, they've been all favorably impressed with our residents. The cosmetic clinic's another one. I mentioned the journal club. We have, and then we have social events such as having visiting professors, which we have included clinical faculty as the speakers. Social events, they all come to graduation and to other social events that we have a few times a year. And didactics, we've included them for lecturers. The resident cosmetic clinic, I think, is our best involvement in terms of clinical faculty volunteering. We have 6 faculty who each do 2 months apiece. And when they do this, they attend a couple of clinics, but we actually have block time for the residents to do cases with them. And they give up one Wednesday every week for 2 months to operate with our guys. And that's a big commitment, and we have six people who are fabulously committed to this and have been for a long time. It's been the same people for many years. We've changed over a couple people for various reasons. We have basically, we charge the patients about 10% of what it would cost to have the same surgery in the community, and all that money goes into our resident education fund. So I feel like our residents are paying their own way to go to meetings. The other thing we've done in the past several years is Loupes ceremony, which we do annually. All the PGY2s in general surgery as well as plastic surgery are given Loupes at the beginning of their second year. But we do this as each set of Loupes is given in honor of a faculty, either a faculty person or an alumnus of the program. And in the last 3 or 4 years, we started having a dinner where we invite the honorees as well as the recipients, and so they get to meet each other the night before. It's actually not a bad fundraising idea, and then the Loupes are presented at grand rounds with a little bio of the honoree. I got one of my residents to send the cover of, this is what's on the cover of his Loupes, and if you can't read the little print, it says, in honor of Ray Kaufman, who actually was the first graduate of our program in 1952, or 51, and Ray was also, as many of you would know, he was the president of ASMS a long time ago. He's the person who got me in ASMS, and it says, in honor of Ray Kaufman and the everlasting pursuit of academic and clinical excellence. So we try to always do this in a way that honors them. And when these were awarded, Ray just passed away a couple months ago. But he came. He was 92 or 3. He was still golfing at that point, and it was really a nice thing to do. And it's a good way of honoring the faculty and having them feel again. I think the fact that they feel appreciated is the most important thing in terms of encouraging their teaching and participation. And I think, as you can see, the main thing is that we don't have a town and gown thing. We actually have a lot of respect for our clinical faculty and want them to participate. And I think that has been a way of including them in our program. Thanks.
We have time for one question. Andy.
Oh. There's a place for a microphone.
Appreciate that talk. I think just like each one for UCSF. I'm so sorry. All right, as my resident can tell you, I'm not very good at yelling. But we have abundance of talent in our private, or I should say, part-time faculty, that's what we call them, in the Baltimore, Washington area as well. But I think what draws those people to our residency and program is not just the stimulation and fulfillment in teaching, but also the academic title, which they get to use on their stationery and website and so forth. So a few years ago, we instituted a requirement in order to be a part-time faculty member, and that is 20 hours of hands-on teaching per year, in addition to attending grand rounds and as well as a resident research day at a specified frequency. And I think we've made that work well. It not only enhances teaching for the residency by drawing talents from the community, but also made the academic title more meaningful. So just want to share with you what we do for our program.
So how many academic units have a requirement for a specific amount of hours of service to have a clinical faculty position? I think you'll see more and more of those moving forward.
We actually do, although we don't really measure it very accurately. But these people, the people that are on that list are all doing I mean, certainly the people who are doing the resident cosmetic clinic, in 2 months they're doing 100 hours or some large number. And the other people on that list that say at the Bunkie Clinic are doing hands-on teaching with our residents year-round. So I think they're actually all fulfilling that goal.
Thank you. The second topic is one that's important to all of us, both in our professional and personal lives. Heather Furness is going to talk about broadening the diversity of your residency team.
Thank you. The title of my talk is Broadening the Diversity of Your Residency Team. Let's see, this is, how do I go? Okay, thank you. This photo was taken in 1989, the year that I did a microsurgery fellowship with Dr. Harry Bunkie. 10% of our team was female, which was actually an overrepresentation if we compare it with the percentage of ABPS certified female plastic surgeons that decade, which was 6.9%. This slide is courtesy of the American Board of Plastic Surgery, and it shows the increasing percentage of women among certified plastic surgeons by decade, with the last being our incomplete decade. This slide is also courtesy of the ABPS, showing the raw numbers of women who are certified per decade, again with the last bar indicating an incomplete decade. So the numbers of women in plastic surgery are increasing. This chart is courtesy of the ASPS, and it shows the gender distribution of 2017 ASPS active membership. 16% of all members are female now. This is an increase from last year, 14%. But among residents, 35% are women. So again, women are increasing in numbers. Now let's look at ethnic diversity in plastic surgery versus the US population. The numbers that I use for this chart come from a paper published in PRS in 2009 by Butler and al., entitled Ethnic Diversity Remains Scarce in Academic Plastic and Reconstructive Surgery. The blue bars indicate the percentage among the US population, the red bars, the percentage among plastic surgery residents and fellows, and the green bars, percentage of plastic surgery tenured professors. If we look at the extreme left, we can see that Caucasians are slightly overrepresented in plastic surgery residencies compared with their presence in the US population. Asian Americans are also overrepresented in plastic surgery residencies compared with the general population. But African Americans and Hispanics, or Latino Americans, are underrepresented in residencies compared with the US population. So if we look at these three underrepresented groups, we can see the females in blue, African Americans in red, and Hispanics in green. And we can look at their distribution in the US, medical schools in general, and plastic surgery residencies and fellowships. We can see Women have a representation of 50.8% in the U.S. population, and this drops slightly in medical schools now. A few years ago, there was parity between men and women, but this has fallen slightly since then. And then we can see that they fall more significantly when they enter plastic surgery residencies. Let's look at the African American red bars. We can see that they are 12.3% of the U.S. population, but there's a fall off when they reach medical school, 7.1%. Another fall off when they reach plastic surgery residencies, where they're only 3.7%. Hispanics make up 14.8% of the U.S. population, and there's a big drop-off when they go to medical school. They're only 6.7%, and then, interestingly, there's a very slight fall-off when they go into in plastic surgery residencies, where they make up 6.2%. So why does diversity in residency matter? Well, it may impact patient care. There are studies that show that some patients seek gender and ethnic concordance. The paper that I mentioned by Butler et al. Posited that underrepresentation of ethnic groups may contribute to health care disparities. And they give the example that African American women are less likely to get breast reconstruction compared with Caucasians. This study is just published in this month's Aesthetic Surgery Journal, and it's based on a study that my co-authors and I did in our practice. I am in practice with my husband. We've been in practice the same amount of times. We have similar experience, similar reputations. Our patient coordinators asked inquiring patients whether they wanted to see a female or a male doctor. Nearly half of patients didn't care. 27% requested a specific doctor by name, but 26% requested a female, and only 1% requested a male. Now, all of the inquiring patients were females, so they may also have been looking for gender concordance. Another reason diversity matters is that it may spawn innovative thinking. This has been found to be true across industries. This quote is from Candace Morgan of Pinterest. She says, "Diverse teams, in terms of demographics and thought, outperform homogeneous teams on innovation and problem solving." There is also an indication that there may be possibly better performance with diverse teams. This paper from JAMA Internal Medicine was just published last month, and they compared male and female hospitalists with their respective patient outcomes, and they found that patients treated by female physicians had significantly lower mortality rates. So how do you broaden the diversity of your residency team? First, look, and I think in your own organization, who is underrepresented? I've mentioned the three groups who are nationally underrepresented: women, African Americans, and Hispanics. And then ask, why are those groups underrepresented? Possibilities include overt racism and sexism, unconscious bias, and then the underrepresented groups may themselves experience internal gender or racial bias, which is manifested as lower self-confidence. They may be intimidated or ostracized by the surgery culture. And few female and minority faculty and plastic surgery leaders may leave few role models for those underrepresented groups. One barrier impacting specifically women is a long surgical training during peak fertility years. This chart comes from a study just published in January at PRS. It's based on a survey that my co-authors and I did of plastic surgery program directors. We had a 61% response rate. Thank you to those who did respond. And we asked them how many had maternity policies in place. And only 36.5% said that they did. And of those policies that were in place, many of the elements in complete policies were not in place. So this difficulty in combining pregnancy with these long training years means that historically, women plastic surgeons have had higher infertility rates than those in other specialties. They've had higher abortion rates during residency, which has been unknown to program directors. They have a higher childlessness rate and higher pregnancy complication rates, particularly associated with heavy call, long hours in surgery, and particularly during residency. PRS is currently publishing a series of articles and videos on women in plastic surgery. Last month, they just posted this video on their YouTube channel, Women in Plastic Surgery, Pregnancy. If you haven't had a chance to view it, I encourage you to take a look at it. This quote that I'm taking from the video comes from Dr. Victoria Vastine. She says, "A lot of people don't realize the pressures that are being placed on women to succeed in this male-dominated field." Broadening the diversity of your residency team isn't easy. It may mean a change in culture, and it may seem insurmountable. It takes time, and it takes planning, which is why it's so important to articulate why it's worth the effort. A first step is to welcome plastic surgeon mothers by having a standardized maternity policy and also establishing breastfeeding allowances. Competency-based training, which I understand is coming about, will give greater flexibility to training programs. And there may need to be a cultural change that welcomes pregnancy among residents. This quote comes from an article published in November's PRS entitled "Understanding and Overcoming Implicit Bias in Plastic Surgery" by Phillips et al. Another step is to recognize unconscious bias, and it's exemplified by this quote. Reference letters written for men are more likely to mention accomplishments and highlight publication and research activities, whereas letters for women are more likely to include adjectives describing effort versus achievement, information regarding their personal life, and gender stereotypical traits. So this is important both if you're writing a letter and also if you're reading a letter of recommendation. Another step is to diversify faculty in leadership. This will help to reduce stereotyping, not just for medical students who are looking at what specialty to apply to, but also for the greater public at large. And it's been shown that active mentorship and sponsorship can help retain these faculty who are underrepresented. This slide comes from the Association of American Medical Colleges, and it was done as a result of a survey they did to try to increase the representation of women on medical school faculties. And it showed that women respond with high levels of engagement and satisfaction, with clear expectations about their role in the path of advancement, an equitable and diverse workplace, and access to opportunities for development and advancement, which would probably enhance anyone's long-term establishment on the faculty. Across industries, the key to success in increasing diversity is to hold an individual responsible and to set meaningful, measurable goals, and then to measure progress. Because if it isn't measured, diversity is less likely to be improved. Thank you.
Janice.
Thank you very much. Janice Lalikos, University of Massachusetts. This is obviously a very hot topic across the board, not just in medicine, but all of STEM. I would encourage everyone to try to get involved. And a lot of us, most of us are parents and if you have daughters, this seems unnatural. try to get involved way earlier down the line. I am involved in STEM engagement in the middle school level. This is when girls start to internalize the limits on them, and regardless of any bias that's put on them later, they internalize what they think they should and shouldn't be able to do. And I'm talking about minorities, I'm talking about women, I'm talking about getting them to understand their place at the table. Now, obviously, I'm quoting from Sheryl Sandberg, but I applaud you. Get going earlier.
Thanks. Barry.
Thank you, Heather, for a very nice presentation. I'm Barry Noon, Philadelphia. For many years, we have attempted to have as many board examiners at the American Board of Plastic Surgery oral exams as at least as many women, or diversity, not only women, but all diversity, as we have candidates or applicants. It has been working. Over time, we've shown that we are interesting more women in becoming board examiners. However, it's reaching a plateau, and it needs to be emphasized that women, when they finish their residency programs, need to get into leadership positions and academic positions and express interest in doing such thing. Because if it's 35% in residency, we certainly don't have anywhere close right now to 35%. But the residency graduates are going to increase, so the women examiners at the board have got to increase. Thank you.
Thanks. Jeff.
Jeff Friedrich in Seattle. Great talk. You mentioned in several slides about underrepresented minorities, and I think we'd all agree that we'd like to drop that under modifier and just have them represented. But I guess my question is, what do you suggest we peg that to in terms of that representation? Should it be national proportions, citywide, countywide, statewide? Because obviously there's regional differences. So what are we striving towards in terms of getting to that representation?
Well, I think that probably takes a lot of thought, discussion, because it may be that 50-50 isn't appropriate for male-female, but I think we should also look at why it wouldn't be. And so look at, why, but also why not.
Thanks. The next topic is one that's of importance to all of us in terms of funding our research, education, and global health activities in a period of diminishing reimbursement. Charles Verheiden is going to talk about creating endowment funding for your residency initiatives. Thanks, Charles.
Thank you. Thank you, Mike. This is an issue that every program director in the country faces, decreased funding and increased cost. We certainly don't, at our institution, Baylor Scott & White in Texas, welcome to Texas, by the way, don't have a lock on this issue, but we've been reasonably successful. This is a room in our basement where we keep our extra change. So what are the pressures? There are a lot of changes coming down the pike, some of which are in place. One of these is that specialty care is not getting reimbursed at the same sort of rates as it used to be. The disparity between specialty care and primary care is different. There are also a limited number sometimes of residents. We've had pressures put on us to decrease the number of residents in our institutions. So far we've been able to resist that. But you may be facing a situation where you have to fund 1 or 2 or 3 of your residents outside the usual GME funding mechanisms. And an example of this is in Texas. The legislature a couple of years ago, after many years of being hit on by the Texas Medical Association and every program director in the state, appropriated $53 million for GME funding. Since there were more graduates from medical school in Texas than there were residency positions. Well, how much did we get out of that? Not a penny. So they're not anxious to fund plastic surgery residencies specifically. Coming from the other direction, even though the funding is going down in multiple ways, the costs continue to go up. And here's resident salaries in our institution. And as you can see, they've gone up. And over a 10-year period, that's a 25% increase. And I suspect the next 10 years we'll see a similar number, if not greater. So the costs are going up. The reimbursement is coming down. So what do you do about that? We have tried multiple ways to increase our development support. And these are I'll talk about each one of these briefly individually, but these are the sources that can be probed for development dollars. First of these is your own faculty. We're very proud of the fact at Scott and White that the plastic surgery division is the only one in the institution where all the members of the faculty are in the Caduceus Society. In our institution, the Caduceus Society is those people on the faculty who have given $10,000 or more to the institution. So we've been successful in doing that. But former faculty also can be a good source of development dollars. There are always naming opportunities for conference rooms or visiting professorships or things like that. The other thing that we have done is to recruit our other support staff, and this includes secretaries, our medical assistants, the nurses, PAs, the ladies that work at the desk. And these are not going to be sources of large amounts of dollars. Even if one of your employees is donating 15 or 20 bucks a month, it still helps to include them on the team in your unit. So, and we have several of our support staff employees that contribute. And again, it's not big dollars, but it's very good for morale, very good for team esprit de corps. Another source is patients. We all know that this can be a good source. This is a little brochure that we hand out to patients that we think might be interested in supporting our cause. On the inside of it, we have patient stories. There's one there about a little boy. We replanted his hand and forearm. Another was a lady that had some burn reconstruction. And patients are very responsive to these sorts of efforts. Every patient we have knows what we did for them, but they don't really know what else we do. And that's a problem for all of us in plastic surgery. Former residents is another source. We have a couple residents that have us on a monthly sort of withdrawal from their bank account. And that's really helpful because it's regular and again, not huge sources of dollars, but there's some. We have one of our residents that pays the American Board of Plastic Surgery application fee for the graduating residents every year. We have one resident that buys snacks that go in the resident room, and so all our residents get fed on these snacks that one of the others, former residents, is paying for because they enjoyed that when they were a resident. We have residents that contribute to the Loupes, like Bill was saying. They have a ceremony there. And that's a good idea. We might start having a ceremony. But a couple of our residents actually supply the money for Loupes. Books is another thing, and then certainly one-time gifts is another source. Now, all of these, or most of them anyway, there are probably not a lot of residents that would just walk up to you and say, how can I give you some money? Most of the time, this requires an ask, and this is difficult for practicing physicians of any ilk, certainly for myself and other plastic surgeons. But there's not a whole lot of people that are just going to walk up and ask you how much money they can give you. You usually have to ask, but we have found, particularly with former residents, they've been very responsive. If there's some need, that they will very often give, and sometimes they'll be quite generous in doing that. The other place is the public. We've teamed up with the Plastic Surgery Foundation the last several years in our Broaden activities. And this is just little brochures that we passed out to our patients and to the public. And we've had a very successful event, and we've done things like buying tattoo machines for our breast reconstruction efforts, tattooing nipples. So partnering with the PSF or other activities, we've had runs to raise money and various other things. So the public is a good source, but sometimes it's very difficult to hook up with significant sources of money. I checked the other day, and there are about 2,400 private foundations in Texas. But many of these are limited in who they contribute to. For example, there were several I saw that only give money to charities in Brazos County. There are others that have very specific types of charities that they will contribute to. So I found out this when we were trying to raise money for the PSF, that linking with a private foundation is a very difficult thing to do, but it requires persistence and many contacts and much development of relationship to make these sort of things happen. But if you can find one that your efforts link with and they can identify with you, then this can be a successful source. So this is the one that we all enjoy because these are sometimes the sources of big dollars, finding a sugar daddy or a sugar mama. And Daddy Warbucks is sort of the quintessential sugar daddy, and maybe that's where that term came from, I don't know. But we have, for example, one lady who gives us all the money we need for our mission trips. In fact, there's more than we need. We're trying to figure out how we can spend all this money that she gives us for our overseas mission trip efforts. So if you can find these, and sometimes these are very big hits, sometimes in the hundreds of thousands or even millions of dollars. So one of the things I would really encourage you to do is to develop specific ways and specific places that people can donate money to you. These are funds that we have at Scott & White that people can put money into, and we have sort of a catch-all one called our development fund. And when money goes into that fund, the chief of plastic surgery is the only one that can decide where that money gets spent. The former residents, for example, will often give to the education fund. There are dollars given for research. I mentioned the lady that gives, in fact, completely funds all our mission trip efforts. And then there are specific things like Broaden, for example. But the importance of establishing something specific is to prevent people giving money because of something you've done. And we've had this happen. That's why we did this. They've given money because one of our faculty or staff has provided good service to them. They want to give us some money. They give money to Scott & White, and it goes into this big black hole, and the Division of Plastic Surgery never sees a dime of it. So I would, and in all your conversations and your literature, you need to delineate these specific opportunities. But the key to all these things is relationships. It's very different from the way we usually do our business. We see a problem, we do an operation, we fix it. And there's a very short time period from the initial step to the last step. But development is not like that. You may make some contacts, develop a relationship, and it may be many years before that pays off. And it's a very different mindset. But the key to it all is developing relationships with each one of these folks that we've mentioned here. For example, we start talking to our residents at their graduation party about giving us money, and many of them do, and so we appreciate that. So we'll answer questions if you have some. Thank you.
We have time for 2 questions or comments. You win the race, Guy.
All right. Thank you very much. It hits home. My name is Guy Stoffman, University of Pittsburgh. So for the last 2 years, I've been president of our Alumni Association. And we have to get more involved. And doctors aren't good about asking for money. The relationships have to be, we have to find out, like you said, where the money is going, because you can't just assume that money that's going to be earmarked for you, you're going to get. So you've got to develop relationships with the groups that are collecting it. And you just don't want somebody that doesn't have any skin in the game to just ask for it. So you've got to be a part of that as well. The other thing that I think that is key, anybody that gives you something wants something in return. And so the Cowboys, for instance, I think that's a team that plays somewhere in Texas, but that branding is important. So we want our alumni to feel proud about being where they came from. So do you give them a fleece for an X amount of dollars that they've contributed? Do you establish our Wednesday morning conferences were like a religious experience. So do you be able to let them beam in for the Wednesday morning activities as a membership? And so we're trying to figure out ways to give value back and just not to put your name in a brochure. And I think the more creative we are, the easier it's going to be to solicit money.
Thanks. I'd say that in the last 30 seconds that while getting the gift is hard, I think what Guy's getting at, for those of you that are new to development, the stewardship of the gift and the effort it takes after you have the gift is much more effort and work to sustain that over time. Andy, last comment?
First, I agree with your last comment wholeheartedly. Stewardship and follow-up is important, building a relation. I want to point out that even though alumni and physicians are an important source of giving, they're but a small source. We have a very similar fund as what Guy just described for Pittsburgh and have been successful. But physicians nowadays can only give to a certain amount, maybe with a couple of exceptions. I think we really need to focus on grateful patients with means as well as foundation. And philanthropy is, there's a big science to philanthropy. Our department has a full-time development person focusing on philanthropy that's paid half by our own department and half by the institution. And she helps us look after a patient with capacity, develop relation with them herself, because she's the professional. We're not good at asking at all. And then eventually pay fruit. And I can tell you that the salary that we pay for her has a return many folds in terms of the return.
Thank you. The final topic is one that's critical to the success and growth of plastic surgery moving forward, is how to develop financial support working with your institutions, DIOs, to expand and gain residency and fellowship positions. Joe Losi is going to give us a few thoughts.
Thanks, Mike. Bill reminded me as we were walking up here this morning that somebody once said, you know, it's not just about the money, it's all about the money. And that is for sure when it comes to this topic. And again, Mike asked to talk about developing financial support for expanding your residency and fellowship positions. So just a little bit about, what about the history of how our residents get paid? Well, we know Halstead has been widely credited with establishing the first residency program in the United States in 1889. And from that time until 1965, hospitals basically covered the cost of graduate medical education. Residents or postgraduates in this training program were given room and board and expected to live in the hospital, and they were fed and trained there. And this all changed in 1965 with the Department of Health and Education and Welfare and the Social Security Act. And we can see here as President Johnson is signing in Medicare and Medicaid in the Social Security bill. And this brought GME funding publicly, and it brought, therefore, to a public opinion as well. So how does Medicare fund our residencies? Well, through two different ways. One is direct graduate medical education, or direct GME funds. And this is money that is given by the federal government to cover resident salaries, budgets, and faculty overhead. And the federal government funds about 100,000 residency spots a year. That's about $3 billion in 2009 dollars. The second way is indirect medical education, or IME funds. And these are reimbursements to hospitals and health systems for higher operating costs and teaching activities, such as an increased length of stay or taking care of higher acuity patients. And in 2009, this represented about $6.5 billion. Now, Medicaid also does, as we just heard about Texas giving money. Now, this is not federally mandated, but it's a state-by-state budget of both direct GME and IME funds similar to Medicare. And in 2009, that represented nationally about $3.8 billion. However, there's been cuts to this every year, and we should expect continued reductions. So direct GME and IME payments represent about $13 billion worth of public funding every year for our residencies, and it's hospital specific. It depends on your institution's share of Medicaid and Medicare patients, and it's based on the resident to bed ratio in your institution. As I said, it's different per state and per hospital. And it ranges anywhere from about $90,000 to $225,000 per resident per year that your institution might receive. And as we all know, the cost of a resident with a salary fringe is about $80,000 a year. So there is some leftover money that is given to the health system. So what are the challenges that we're facing? Well, with the Balanced Budget Act in 1997, the federal government capped the number of residency spots that they are going to fund. It basically froze residency education at a random time point, which was the budget of 1996. And why was it capped? Well, there was a thought at that time that we were going to have an oversupply of physicians. And because of that, the federal government capped the number of training spots at about 100,000. Well, we all know we're over the cap, and it's only getting worse. The domestic production alone of medical graduates every year is increasing with new medical schools, with increasing medical school size, and that functionally surpassed the number of funded GME spots in 2015. That's not to speak of the about 7,000 number of influx of foreign medical grads into our GME training programs nationally every year. So we have an uncertain future for funding. We are seeing reductions in state support or Medicaid-supported GME, and every few years there's attempts at federal legislative maneuvers to decrease those 100,000 spots. And we have a continued rapid expansion of medical graduates. As well, most of us in institutions are over the cap, so that the health system pays for the residencies that are above their allotted numbers. Well, I'm part of a committee at Pitt, UPMC, called the CAP Committee, and it's basically a death panel because we look at the residencies and we are trying to cut these funded, health system funded spots. And because of that, really, the mission of many teaching hospitals are impeded, and many people predict that we face a real crisis, a financial crisis in graduate medical education. So much for the good news. If you've noticed the clock, I've spent a lot of the time talking about the problem and leaving not a lot of time for the solution because, unfortunately, there really is no good solution that I can come up with about this. So what are some strategies, maybe? Not a solution, but some strategies. Well, one, if you want to expand your residency program, sometimes you can partner with a hospital in town that doesn't have residents, but they may have money to pay for a residency spot and therefore have a full-time resident rotating at that location. A lot of people don't know that the VA, with respect to residency funding, is a good source. They have no cap, and they often have enough money to fund a resident without expecting a full-time 80-hour per week effort at that location. And we've seen this certainly in Pittsburgh, where our VA will fund one or two positions and just expect the resident to be there when the plastic surgeons are actively engaged in care. One thing I didn't get into because of time, but back, I think it's around 2009, the federal government kind of reshuffled those 100,000 spots and gave extra spots to rural hospitals. So if you are in a rural location or if you have a rurally designated hospital, they'll often have extra spots available. Certainly, if one residency closes, which doesn't happen often in plastic surgery, you can take on those orphan residents and claim a temporary increase in cap from the hospital that closed. You can engage in international residents. You can partner with a foreign country who will pay to have their residents come and be trained by you. And there's pros and cons to that. If you're lucky and you're related to the governor of your state, you can tap into that Medicare or Medicaid funding that comes from the state level. Probably the most practical way is to partner with your health system and be a good citizen and come with a good business plan, a strong business plan. You know, again, a resident costs about $80,000 with salary and fringe every year, and they work 80 hours a week, so that's about $20 an hour. APPs, PAs, and nurse practitioners, they can make up to $100,000 a year, and they certainly don't work 80 hours, and therefore residents are cheap labor. And that's one thing we learned on our CAP committee, that it is cheaper to have a resident than an advanced practice provider. So, but the tough reality here is that we're not just funding one spot. So if the VA gives you a funded spot, well, that's good, but if you're an independent program, that means within 3 years you're going to need 3 spots funded, and if it's integrated, you'll need 6 spots funded. So it adds up quite a lot. So it is tougher than just finding a residency spot. How can you expand your fellowships? Well, one way, it's because they're usually just a one-year spot. You can do that through endowments. You can find some industry support to offset the cost. And then what we've done is you can hire the fellow as a junior attending and expect them to take some call and pay some of their own salary, allowing you now to run 2 rooms, particularly with the overlapping surgery regulations that are becoming more reality every day. So it's certainly it is an uncertain future for sure. And then we don't have time, but what about the competency model of training? And if you have to extend somebody's residency a little bit longer, who's going to pay for that? And will that be offset by the resident that may graduate early? So I hope I brought some thoughts at least. There's really no good solution, but I'd be happy to discuss the problem.
So we have time for about 2 comments. Joe.
Joe, I just want to emphasize something you said towards the end. And I learned this from Peter Quinn, who a number of you know is the Vice Dean for Clinical Affairs. And he sits on, they call it the Rat Pack. I don't know what it stands for. I nickname it the Rat Pack, but it's the same thing. It's a group that will seek to fund the unfunded spots as residencies try to grow. And we were doing the same thing, trying to expand our residency, and there were no spots. And he made it clear to Ben Chang and I that look, adding an extra resident is a lot cheaper than adding 2 or 3 APPs, and that's the real argument. The hospitals need the people power so that they can get their DRG money, and you know, that's the argument that I think is most effective.
Arun.
So yeah, I want to apologize. I'm taking one of Linda's spots because she wanted to speak. But as our regent to the American College of Surgeons, which Linda Phillips is, I just wanted to say that really we need to take the argument for this increased GME funding beyond our organizations, go to the ACS. The one question I have for you, Joe, is as we do that, there's a dichotomy between what the ACS says and what the ASPS says regarding direct and indirect GME funding. The ASPS advocates maintaining that position, whereas the ACS advocates combining. The problem with combining is that hospitals can be much less specific in resident education because they can put it to their general hospital maintenance funds. What is your thought as we try to align with the ACS in that position?
But that's a real problem, because if you combine direct GME funding and IME funding, well, you can make an argument on both sides. There's good for it and bad. I don't know if I have a strong opinion over which way. The reality is either way, it doesn't help us, because if you're a hospital for whatever reason where you get $200,000 per resident spot in direct GME funding, that over the $80,000 you don't have a lot of control of. And healthcare, big academic hospitals have used that money to really treat indigent patients. So that money isn't, somebody's not taking that home. It's being adequate, it's being spent on the health system. So I'm not sure I have an opinion as to whether or not there should be a combination of, combining those two pots of money. Yeah.
There are a lot of smart, dedicated, and experienced people in this room, and we need to work together to solve these 4 challenges to secure the future of plastic surgery. So make sure you continue the conversation during the break, over dinner, or as you have visitors. These are important to all of our future. I would like to thank our panelists for doing such an excellent job this morning, and ACAPS wishes to thank Jim Zins and the board of the association for again allowing us to have this key time during the association meeting footprint to present ideas and concerns about plastic surgery education, which impacts all of us. Thank you.